On the screen, as promised, the former Senate Majority Leader, Dr. Bill Frist of Tennessee. Thank you very much for being with us this morning. He's out talking health care with the new book that he's written, a memoir, A Heart to Serve, as the focal point of those conversations. And we're going to talk with him not only about his work in healthcare, but also some of his observations about the political process going on around the debate in Washington. We've pulled one quote from your book that I want to just get right into the healthcare debate with you, that suggests what the overall goals you think ought to be, and I hope we can put that on screen. For me, a 21st century American healthcare system should be patient-centered, consumer-driven, and provider-friendly. All right, that sounds good as top-line goals. How do you get there?
You know, it is in line with what is going on in Washington today, but the problem that the administration is facing right now, and the Finance Committee in marrying these 5 bills, is not so much how to get the uninsured into the market, because you can do that. You can just pull them in, you can buy them, you can give them subsidies, but it's how you bend the cost curve, using Washington language, how you affect health care cost inflation and spending. For the last 15 years in this country, people out there paying for health insurance have had their premiums go up 3 times faster than wages, and that simply can't be sustained. And the challenge the policymakers have, and what the papers say and what is the reality, is there's not very much in there to slow down that cost curve. And if you bring in 20 to 30 million people and costs still go up and spending goes up 3 times faster than wages, it simply can't be sustained over time. And these would be empty promises, and you'd have to reverse whatever benefits you give. And that's the challenge, and that's the debate. The consumer-driven, patient-centered, not Washington-centered, but patient-centered, consumer-driven, meaning hundreds of thousands of different decisions made every day, centered around value, outcomes, results, and not just doing more stuff or more volume or more quantity. That's not really accomplished in the bills either, value versus quantity. And you have to do that through reimbursement. And the third thing, the provider-friendly, and everybody leaves it out, and all 5 bills leave it out. And what that means is that the medical students that I teach right now at Vanderbilt, when they look up to me last week and say, I'm going to be sued over the next 15 years 3 times for anywhere, each one for $3 to $5 million, and each suit's going to go on for 3 to 4 years, and I've done nothing wrong. Why aren't you doing something about that? And also, we're graduating with $120,000 of debt, the paperwork and the increased regulations. So the provider-friendly I throw in there, because no matter what you do with the healthcare system, if you drive the young nurses out, the young doctors out, the social workers out, the system will implode over time. So there's no tort reform, no malpractice reform in the bill, and we have to be careful with all the mandates. So that's what the 3 things mean. And so it's a different approach in how you get there, bending that cost curve, using more markets, transparency, accountability, value, outcomes, instead of just reimbursing more stuff.
We've got the phone numbers on the screen. If you watch a lot of public affairs television, and I know you do, you might have seen Senator Frist on a number of programs this week, and you hear some of his thoughts on health care. We want to get to your calls as quickly as we can. That's the beauty of this program. You get to ask the questions, and we'll get to those soon. I'm interested, I wanted to go to your experiences in working as a young resident for the British healthcare system, because you write about that in the book. Your takeaway was, as I understand it, that a government-run program would never work here. But your writing about it was not without some positive observations.
Oh, yeah.
So what would you?
So first of all, what the Obama administration is doing is not socialized medicine. You'll hear a lot of people at the extreme say, socialized medicine coming in, going to control everything. Socialized medicine is where the government owns the hospitals, they own the doctors, and they decide how much people are getting paid. And that's not what's in these bills. The fear, and we'll come back to the public plan, is that we sort of have federal government take over. And that's not necessarily a socialized plan. And I wrote about in A Heart to Serve, as you said, I spent almost a year as a doctor, as a heart surgeon, working for the British National Health Service. That was a socialized system where all the budgeting, all the control comes out of London. And therefore, around November and December of the year, hospitals start scaling back. I talk in the book about keeping a list of 100 patients. We do 3 patients a day, no more. People would go home at 6 o'clock at night because the hospital budget didn't pay the nurses, or my perfusionist running the pump. And people came in the middle of the night, we'd say, you just have to wait till tomorrow. That wouldn't happen in America. And that solidarity of everybody getting the same, therefore that's okay, is just not the American way of doing it. But as you said, there's some great things about the system as well. Primary care. doctors actually there are still making house calls. Now, I'm not sure if that's efficient, but the primary care, basic care, those physicians get paid more than primary care physicians here. Here, the specialists get paid. Primary care people get paid nothing there. I think from preventive care, it's probably better there as well. And my point is the socialized system where the control is not consumer-based or patient-centered, which I argue for, but is made by 6 or 7 bureaucrats out of either Washington, D.C. here or in London, is so far from the intimacy of healthcare. If you have breast cancer coming in, I want to do everything I can for you. I don't care what it takes. Well, some bureaucrat up in London would basically say, no, you're not going to get the latest in breast cancer therapy. And therefore, people in this country do better if they've got breast cancer or prostate cancer. It's more expensive and very inefficient here, but also very inefficient there.
Well, to that end, will you tell the story, though, about observing the patient who was using an old-fashioned nebulizer?
Yeah, that's another great one, because if you look at healthcare costs in the debate here, to me, healthcare costs are basically, in this country, trying to bend this cost curve, is technology. And that's good stuff. I do heart and lung transplants and do artificial hearts and use lasers. All that is good, but it's very expensive. So when I went over there, and I was a heart surgeon, I was making rounds one day, and I was looking for, after my surgery, a nebulizer. You put a little mask on, you have a chemical that's nebulized, it goes to the lungs, it keeps your lungs free. A little piece of equipment, pretty expensive. You have to have a nurse come out every 4 hours and help you with it. It wasn't there. I said, where is it? And it wasn't there. And what was there was a big old pot, an earthen pot with a cork in it, and a big old tube came out, and every 4 hours the patient would reach over, get it, and then they cough, which is what you want them to do. I said, what's going on? I said, what's in that? And they just put in eucalyptus. That's pretty cheap stuff. It's good stuff, and it works equally well.
So what's the lesson?
Well, the lesson is looking at value. You look at outcome, you measure what is the product of it, a cough, keeping those lungs open, and then go back and say, for every dollar invested, what does it get the best value? We tend to reimburse for that nebulizing machine and the chemical itself that nebulizes and the person who comes in without any questions asked. And that's why I say, and this bill misses it, all 5 bills miss it. If you reimburse not on volume, not on quantity, not on more stuff, but on outcomes, on performance, on value to the patient, what works. And we got to get smarter about what works and what doesn't. But to me, if we're going to really get effective, cost-effective health care in America and be able to bring in the uninsured, which I believe, a lot of Republicans say you shouldn't bring everybody in. I believe you do need to get people in the insurance market for it to work, for it to really work. But you have to come with a value-based and not a volume-based system.
I want to show the book cover again. We showed just before you came on board that you're 57 years old. We learned in the book that this is your 7th. Why a memoir at this point?
You know, the title is A Heart to Serve, and I use that as a title because I spent 20 years in medicine serving one-on-one, and then I lost my mind and came to Washington, D.C. Not really, but people think I did back at home, because why would you stop doing heart transplants in order to come to this place, to Washington, where, you know, it's a sausage factory. It's tough. And to me, it's the same sort of, and this gets to the subtitle, the passion to bring health, hope, and healing. Instead of healing one-on-one, you're looking at the health of a community. And indeed, my work overseas, the health of the globe. And to me, it's the exact same thing. To bring a more productive life, a more fulfilling life to people, and you can do it through politics and policy. A lot of people say, come on, you can't. But if you go back and look what we did with prescription drugs, there are 30 million people out there who have affordable access to prescription drugs, or HIV/AIDS around the world. There are probably 5 to 10 million people alive because of this crazy town and the leadership that emerges from here.
Some have suggested that the reason for a memoir right now is perhaps a desire to return to public life again.
Yeah, I make that very clear in the book. I'm not running for anything. I'm not running for president, positioning for vice president. I'm not running for governor. I'm out of elected politics. And people think that's straight. How can this guy say that? You know, he's not that old. And it comes back when I came here in 1993, unlike most people here, said, I'm going to serve 12 years in the United States Senate. I'd spent 20 years in medicine serving one-on-one. I'm going to spend 12 years here, and then I'm going to go back home. And then as I went up and became majority leader, people said, well, no, he's not going to go back home. He's going to stay. He can be leader or minority leader of the Senate. And I said, no, I'm going back home. And in fact, I'm back home, been there for 2.5 years, going to stay in Nashville, live in the same house I grew up in. And that is this concept of the citizen legislator. It may not be for everybody, but I think we need more citizen legislators here. And I'll say one last thing.